Welcome to Samaritans First International Health Forum. Thank you for joining us today. We hope you participate in our conversation. You can chat with us in the side chat box beside the video, and we hope that you do that. We will see that and answer questions and see your comments, so please do that. Before we begin today, let's just open in a word of prayer. Father God, we thank you for the opportunity to come together to learn about this important topic, and we pray that you would just reveal yourself and more to us each day as we serve you, and give us wisdom as we treat patients and see people all over the world, Lord, with different conditions, especially leprosy today. As we focus on that topic, Lord, give us wisdom on how to best treat and manage those patients. In your name we pray. Amen. We're excited today to have Dr. Lance Plyler with us. He's not only the founder of our International Health Forum, but he's a graduate of UNC Chapel Hill School of Medicine with more than 15 years experience in international medicine, hospital-based medicine, and palliative care. Dr. Plyler is currently the medical advisor for Samaritans First and has worked on the front lines of many medical responses, including the post-earthquake cholera epidemic in Haiti and the deadly Ebola outbreak in Liberia. Later today in the show, we will also be joined by Dr. Paul Saunderson, who is joining with us from Norway, and he is the Medical and Research Director at the American Leprosy Mission. But today, Dr. Plyler will be starting our conversation.
All right. Well, thank you so much, Beth. I really appreciate you helping host our forum, and delighted to be here today to speak about this very important topic, leprosy. I'm also, as Beth alluded to, will be joined later today by Dr. Paul Saunderson, who is a world authority and works with American Leprosy Mission. I'm going to be really addressing the more clinical perspective of leprosy, and Dr. Saunderson subsequently will be discussing diminishing transmission rates and the aspirations of total eradication of leprosy. So with that, let us get started. I've entitled this Antiquity to Eradication. As many of you probably know, leprosy really has been widely recognized in many civilizations throughout history, including China, Egypt, India. In fact, it's first documented in about 1500 BC, in which there is Egyptian papyrus documents that alludes to the disease. So it has been widely recognized and problematic throughout the centuries. Fortunately, it's a disease that is starting to respond to global efforts for eradication, but still very much problematic in the developing world. It's also referenced quite a bit, as I have referenced here in the Bible. There's a number of acknowledgments of leprosy in the Bible. One of my favorite stories in the Bible is found in 2 Kings, and it's with regard to Naaman, who was the commander of the Syrian army and who was inflicted with leprosy. And the great prophet Elisha directed him to go wash himself 7 times in the Jordan River. And it states, your flesh will be restored. And so Naaman was obedient, and he went and he dipped himself in the Jordan River 7 times, as Elisha informed him to do, and his flesh was restored, and he became clean like that of a young boy. I wish treatment of leprosy was still that easy, but it is easier with some of our multi-drug therapy programs that are now widely, or have become more widely available. And finally, here's one more picture with reference to another scripture, Matthew 10:8. Christ directs us, it says, heal the sick, cleanse lepers, you received without paying, give without pay. And I love that verse, and I think it's really just as healthcare professionals, I think it's a calling for us to reach out to those in need, including people inflicted with leprosy, and really do what we can to help them. This is a a picture of myself with a lovely woman that I met in South Sudan several years ago, who unfortunately did not receive prompt treatment for her leprosy. Next slide. So let me just start off just to develop a little background about the disease. The eponym for leprosy, you'll often hear it referred to in the literature as Hansen's disease, and this, of course, is after Dr. Gerhard Hansen, who recognized and discovered the disease back in the 1870s. As we all know, leprosy is secondary to a bacterium referred to as Mycobacterium leprae, so it is in the mycobacterial diseases like tuberculosis, Buruli ulcer, and some other common mycobacterial diseases that we're familiar with. Interestingly, leprosy was the first bacterium, or Mycobacterium leprae was the first bacterium to be identified as causing disease in humans. So that's an important historical fact. And from a clinical perspective, it certainly leprosy can involve, you know, any part of the body, any organ system of the body, but predominantly has a predilection for skin and peripheral nerves, and the damage to the peripheral nerves is really what causes the unfortunate clinical impact to people devastated by this disease, and we'll discuss that. And then I think another salient point that I really want to get across today is contrary to popular belief, leprosy really is not highly contagious. It's certainly it's very destructive and deforming to people inflicted with the disease, and I think from that perspective it certainly alarms people and makes them frightful, but fortunately it is not highly contagious. So just to start off too, just to discuss some transmission, and again Dr. Saunderson's going to address how we prohibit transmission to others. It's not very well understood yet. We do know that it is probably via the respiratory route through, and it has to be multiple exposures through nasal secretions or cough droplet transmission, and so that's certainly one of the primary mode it's felt. But we'll talk about other issues too that are very important. It has to be, of course, in an endemic area. Persons that are susceptible to it have compromised immune systems, genetic predisposition. So it's a very complex issue that I don't have the expertise or the time to discuss today. It can occasionally be transmitted via broken skin too, but that's certainly not a very common mechanism of transmission. And then I think a very interesting fact about leprosy that maybe a lot of people don't know, it is zoonotic. Specifically in the United States, in southeastern United States, armadillos actually carry the organism, and it can be a mode of transmission to people. So that's an important point. In fact, just to mention, a lot of people are not aware, but leprosy is still transmitted in the United States. Usually somewhere, I believe, around 200 cases a year are reported. Most of the time that's from persons that have traveled abroad or persons from other countries where it is endemic. And then a very low incidence of cases transmitted again by armadillos. It's not poorly understood, or it's not well understood how that occurs. And then just the last point is most persons that are exposed to Mycobacterium leprae or leprosy, they do not acquire the disease. So again, I think that just speaks to the point that it is not highly contagious. So some of the just characteristics of the organism itself. It is an obligate intracellular organism, so it can't, outside, the cell, it cannot exist. So it is an obligate intracellular organism, and it also is an obligate aerobic bacteria too. So it has to have a aerobic environment to persist. And it is, as the name implies, it's an acid. We always refer to it as an acid-fast bacterium or bacillus. Bacillus just simply means it's rod-shaped with regard to its morphology, And acid fast, it stains. It has a high uptake of this carbofusion acid fast type stain, as opposed to a traditional gram stain that we utilize for other bacteria. Okay. Some of the other, just briefly, I'll just mention some of the other laboratory features of this organism. Sort of with standard microscopy and staining, it does reveal that these bacilli, they present in clumps and rounded masses, and they aggregate side by side. One interesting point too, we are not able to culture in an artificial medium Mycobacterium leprae, so it has to be cultured either utilizing the foot pads of mice or armadillos. The other important point is very, very insidious. It grows very slowly, so you have to certainly be intentionally growing or attempting to grow this organism. Cultures take several weeks to mature. So moving on then, just with regard to physical examination of persons inflicted by leprosy, the lesions, if you've seen them before, they're most of the time they're hypopigmented. It sometimes looks like vitiligo, but sometimes it can be reddish patches on the skin as well. And very characteristic of these lesions, they have decreased sensation or paresthesias within these lesions. It can also be, it certainly is a neuropathy. Again, it has a predilection for the peripheral nerves, and so it can be associated with tingling of the hands and feet. As we all know too, one of the big problems is, is eventually with this neuropathy, they're very vulnerable. Patients with this disease are very vulnerable to trauma of their extremities, so they can sustain burns or other, lacerations or trauma without recognition, and so they get repeated injury to their extremities, which contributes to the deformation and devastating features of the disease. And then also with more classic leprosy, in which we will discuss momentarily, the lepromatous type of leprosy, they have an abundance of bacilli, and they get lumps within their skin. You'll see they have the lioness-like faces, and they get swollen earlobes, and their skin is broadly infected and lumpy. And then finally, sometimes late in the disease, they can even have, even though there is a decreased sensation, they can have a very painful involvement of their enlarged peripheral nerves. Okay, and I just wanted to show a few pictures, just to kind of start to give the audience a feel of clinically what it looks like. Of course, this is more advanced disease. If you focus on her hands, and I'll show you a close-up in a minute, you can see that her hands are depigmented in the palms and then just the lateral aspects of her hand. You can also see that that her digits are missing. Finally, you can, if you look at her face up close, you'll notice that they have a lot of alopecia. See, she's missing her eyebrows, eyelashes. And she's had a lot of, this woman is blind from leprosy. She's had a lot of corneal damage. She has an inability, because of damage to the facial nerve, inability to close her eyes. Again, this is just another close-up just to kind of emphasize the point, the loss of hair. Specifically, you'll see the loss of eyebrows, and notice that this gentleman does not have eyelashes. This is just another picture. You definitely, one of the things as a clinician you can appreciate is if you examine a patient with leprosy, they do have very enlarged peripheral nerves. You can see just below this patient's ear, you can see a very enlarged great auricular nerve. So you can literally, they're cord-like. You can palpate these damaged nerves. And then just some of the more advanced findings of leprosy that you still, unfortunately, you'll see in many aspects of the developing world. There's people that just didn't have timely access to multi-drug therapy, and so they develop these advanced physical findings. They'll develop claw fingers. They'll secondary to damage to nerves like the ulnar nerve. They'll develop absence of digits. associated with the infection and repeated trauma over time. Again, they'll get multiple complications like foot drop, which is associated with the common peroneal nerve. They can get facial paralysis, other neurological impairments, depending on which peripheral nerves involved. And that's the real cornerstone, the real problem of this disease, is that it just causes devastation to the nerves and impairs these people and causes a lot of secondary complications. I already alluded to some of these others: loss of eyebrows and eyelashes, this lagophthalmos, or inability to close their eyes, which can cause progressive destruction of the cornea and loss of vision. And then finally, in very advanced disease as well, they get a lot of mucocutaneous involvement, and they can get collapsed like a saddle nose deformity. Again, this is just a close-up of one of the patients I encountered. If you look closely, she's got a depigmentation in her hands and loss of digits. And then some of the moving on, when you encounter a patient that you suspect with leprosy, how do you make the diagnosis? And I think it's really contingent on where you are in the world. Many times in the developing world, you're not going to have access to laboratory support. So many times, especially in an endemic country, I think we can use a lot of the clinical findings to make the diagnosis, but it certainly helps, which we'll mention too, to have the laboratory support. It is predominantly a clinical diagnosis. And some of the big three here that I've mentioned is the hypopigmentation that you see, and we've seen in the pictures. These lesions are associated inevitably with loss of sensation in the lesion itself. And then, as I mentioned, the palpable thickened peripheral nerves. And then finally, if you do have laboratory support, you note the acid-fast bacilli on a full thickness skin biopsy or a skin smear. And then if you do have, if you're fortunate enough to have laboratory support, they historically have utilized what are called skin smears, but they've a better, I think, format is to utilize full thickness skin biopsies. And they recommend when they get the biopsy that you utilize the most, what appears to be the most active margin from the most active lesion. So a lesion that looks, I guess, most involved, if you will, and take the biopsy from the region of the lesion that appears to be most active. And again, you can do acid-fast stains, which in the more lepromatous type, and we'll talk about it in just a minute. There's tuberculoid type, which doesn't always stain for the bacilli, but the lepromatous subtype of leprosy does. And you can also utilize the biopsies for culture. So just to give you now, just to move into sort of the spectrum of disease, if you're experienced with leprosy, you know there's really, breaking it down and making it really simple, there's what's regarded as tuberculoid leprosy and lepromatous leprosy. And tuberculoid is often referred to as well as palsy bacillary. And as the name implies, it just means that there's really, clinically, with patients with tuberculoid type of leprosy, they really don't have an abundance of bacilli. The count of bacilli is much lower, and that's because the host has a more robust cell-mediated immune response, and so their immune system is able to regulate or at least partially control the infection, and so it keeps the count down. And as a result, they have a tuberculoid subtype of leprosy, which I think is a lot less clinically destructive, and we'll show you in just a second. The lesions are much different than in lepromatous leprosy. In tuberculoid, the lesions are much fewer in number. They're more of a macular type lesion, not the more nodular type of lesion that you will see in lepromatous. On the other end of the spectrum is lepromatous leprosy. In parentheses there, you see it's also referred to as multibacillary. And again, as that name implies, in this case, the host has a compromised immune system, and as a result, they're not able to as efficiently fight off infection, and so I would say the infection is much more overwhelming. So as a result, clinically, you're going to have a lepromatous, in which it's more of the classic picture that you would think of when you think of leprosy. They have extensive lesions throughout their body. They're not nearly as well demarcated. The skin is much more thickened and much more nodular. A lot of times you'll see their face has that lioness type face that we showed a picture of just a few minutes ago. So that's sort of the two extremes of the spectrum. And in just a minute we'll talk about there's subclassifications in between these two ends of the spectrum. So just to make things very simple, especially like when as clinicians we're in the developing world and we don't have all the support to make a classification, a very specific classification. WHO has made a very simple classification mechanism, as I'm describing here. And again, this is more in an austere environment where, again, you have little laboratory support to make a diagnosis. And it's really basically there's the tuberculoid subtype, or again, paucibacillary, and generally in that situation you see 5 or less skin lesions. If you do have access to the lab, you will not, with paucibacillary, you will not have detectable bacilli on the biopsy or the skin smear. And that is in contrast, again, to the other extreme, lepromatous or multibacillary. The lesions tend to be 6 or more skin lesions on the person's or the patient's body, and they do tend to be positive on stain by the skin smear or biopsy. So those are the two big extremes in subtype of leprosy. There is, however, as I mentioned, there's different subtypes that are somewhere in between lepromatous and tuberculoid. This classification system is called Ridley-Jopling and is widely utilized and known. I'm not going to go into exquisite detail. I've already kind of mentioned the two extremes between tuberculoid and lepromatous. As you move from number 1 over to number 5, number 1 being tuberculoid, number 5 being lepromatous, and again, the number of bacilli the patient is infected with becomes much more numerous, and so you, as a result, develop many more lesions, and the lesions become move progressively from a macular type lesion to a much more nodular and deforming lesions. You see the subtypes there are tuberculoid, and then borderline tuberculoid, mid-borderline, borderline lepromatous, and lepromatous. Next slide. And I'm just going to briefly just show you some pictures of these different subtypes of leprosy, just so you can kind of clinically become a little bit familiar with what they look like. Tuberculoid leprosy here is there's just a couple lesions. They're macular, which just means they're flat. They're not raised or nodular. They're hypopigmented. They often may have they're well demarcated, as you can see there with that red perimeter. Next lesion, or excuse me, next slide. This is the next stage. Again, as we move up, again, the patient has been inflicted with greater number of bacilli in the infection. They start to develop more lesions. In borderline tuberculoid leprosy, the lesions look more target. You can see they're still very well demarcated, and they tend to be still macular or flat, but certainly greater in number. In mid-borderline leprosy, again, it's the same increase in spectrum as we're describing. The lesions now start to become a little bit more raised, a little bit more nodular and numerous. And then finally, you can see, obviously, this gentleman has got multiple lesions that are now becoming, again, much more nodular and can become very deforming. And then finally, until you have full-blown lepromatous leprosy, which is the classic, picture of what we envision with someone that has very advanced lepromatous leprosy. They have a very impaired immune system. For example, if a person has like HIV and has a compromised immune system, certainly they're not going to be able to regulate this disease at all, and it's and without certainly treatment, they can develop lepromatous leprosy, as this unfortunate gentleman has. So just some other, just real quickly, wanted to mention just the differential diagnosis. What are some of the diseases that may look similar to leprosy? We already mentioned certainly other mycobacterial infections can involve the skin. TB, we don't think traditionally of TB involving the skin, but it certainly can. We already mentioned Buruli ulcer too, another mycobacterial disease. Sometimes these can mimic leprosy to some degree, especially sometimes leprosy can have can ulcerate and look like some of these lesions. Of course, various fungal lesions, tinea, and other fungal infections can have cutaneous involvement that can certainly look similar to leprosy. Cutaneous leishmaniasis, if you've seen that before, or that also certainly can cause nodular skin lesions and ulcerations that can look very, very similar to leprosy. I guess advanced psoriasis can too. Mycosis fungoides, which is a cutaneous T-cell lymphoma, certainly can have manifestations at times that can mimic that. And then finally, not a disease that we see too commonly, but von Reckinghaus or neurofibromatosis. So that's just one of many of the different infections that can look similar to leprosy. Treatment. Fortunately, we have made tremendous progress with treatment, and again, I'm going to have Dr. Saunderson mentioned some of the advances we've made and with regard to treatment and the diminishment of transmission. But what certainly is paramount is early diagnosis. As you can see, if we do not treat this disease early on, then it can have devastating impact. And I think this is really analogous, like to something like maybe rheumatoid arthritis. If you don't initiate therapy, like DMARD therapy, very early on in the course, it can have very devastating effects that can last a lifetime. So early diagnosis is really critical, and then providing access to a full course of therapy for these patients. We learned that in the 1940s that dapsone was a very, very effective medication against leprosy. They did recognize, however, that monotherapy is associated with resistance, much like we now know with MTB. We certainly have to use multi-drug therapies now, so that's standard of care to utilize multi-drug therapy. And WHO has outlined very carefully regimens that we utilize to treat both tuberculoid and lepromatous leprosy. Unfortunately, even though we're utilizing just predominantly 3 drugs, drug resistance at this point thus far has been very rare. So next, the medications. What are the medications that we utilize? Again, there's 3. Dapsone we already mentioned. Second would be rifampin, and thirdly would be clofazimine. Next slide. So this is really kind of the outline that WHO has endorsed with tuberculoid disease. And again, this is just a general guideline, but in general, tuberculoid does not require as lengthy a therapy, and standard of care is generally 6 to 12 months with combination therapy with dapsone and rifampin. Lepromatous disease, again, we mentioned that the disease is much more extensive. The count of bacilli are much higher, and so of course this is a much more challenging disease to treat. The recommended therapy is 12 to 24 months, and this utilizes triple drug therapy, including dapsone, rifampin, and clofazimine. There is some alternative medications, which I'll just briefly mention. Again, resistance is rare, but minocycline, clarithromycin, ofloxacin are some alternative antibiotics that can be utilized in medical therapy if resistance does exist. The medical portion of the therapy is really the more straightforward treatment. Once we eradicate the infection itself, we still, again, we want to provide that therapy in a very timely fashion, and such that we can avoid damage to the peripheral nerves. unfortunately, many patients throughout the world do not have access to that care in a timely fashion, and they do sustain many of the damage to the peripheral nerves as we've already described, like peripheral, like for example, the facial nerve. I mentioned the ulnar nerve, common perineal, many cutaneous nerves, and so there's a lot of repercussions to patients with leprosy that will last a lifetime. Many of these people get secondary infections. Many of these people have compromised extremities that warrant surgical interventions. And as you can imagine, therapy is critical too. Many of these people, for example, if they have drop foot or they have impairment and weakness in their legs, physical therapy or occupational therapy, for example, patients with claw hands, they're really going to need interventions from these ancillary medical interventions to help them, to rehabilitate these patients and to care for them. And it's really care that lasts a lifetime. So these people really are living with a chronic illness that provides multiple follow-up. So that's just an important aspect of the disease. One other aspect I need to just mention, and for the sake of time, I'm not going to go into a lot of detail. Patients with leprosy also develop immunological reactions. There's what's called a type 1 reaction, which patients with borderline disease are susceptible to. And then patients with lepromatous leprosy are susceptible to type 2 reactions. And I'm going to grossly summarize these or oversimplify, but in essence, it's felt that these reactions are secondary to enhanced immune response to the disease. What you'll see clinically, they'll have fever, malaise, erythema, intense erythema of their lepromatous lesions. They become inflamed, indurated, painful. They can ulcerate as well. And therapies for this is standard care is usually a course of prednisone, a tapering course of prednisone. Oftentimes we'll start around 40 to 60 milligrams a day and slowly tapers over time according to the clinical response. I know that type 2, the type 2 reaction also can respond well to thalidomide. So those are just important reactions that are associated with leprosy that one should recognize. They're also working on development of vaccination. Interestingly, BCG does provide partial protection for leprosy. So BCG is not only beneficial in the developing world against tuberculosis, but also provides some protection against leprosy. I just wanted to kind of conclude here in my portion of the talk, just to share with you just a few quick pictures of patients that I've encountered over the last several years that are inflicted with leprosy. One of the things is, as we have discovered, leprosy is certainly not as contagious as it historically was felt to be. Colonies, however, still certainly exist around the world. I'm sure Dr. Saunderson can allude to, or can elaborate on that quite a bit. This is one called Luri Roqui leprosy colony that I visited just outside of Juba. Unfortunately, it was initiated in 1948, and I think at that time had literally hundreds or even over 1,000 patients, but it has dwindled quite a bit in numbers over the years, and it's just a handful of patients there, but lovely patients that are there that have really formed it's a community. These are patients that are no longer have active leprosy, but are permanently impaired by the disease. That's just another picture of patients that we encountered and were able to visit with. And then this is a picture last year. As many of us know, Nepal was struck by a 7.8 earthquake in April of last year, and Samaritans Purse was fortunate enough to respond in the aftermath of the earthquake. And we were able to partner with Anandaban Leprosy Hospital there just outside of Kathmandu. In addition to responding to the victims of the earthquake, we were also able to help patients, assist patients that are inflicted with leprosy. This was a a boy that I met, 15-year-old boy, really impacted me. My son is 15 years old, and he had significant complications from his leprosy. We unfortunately had to perform a BKA, or a below-the-knee amputation, that you can see right there in the picture. And it was just so disheartening that this boy had to have that done at such a young age. So you can see the implications and complications associated with leprosy can last a lifetime and be just devastating. So I do want to close by emphasizing that we've made tremendous strides forward in eradication of this disease. Just to give you a little bit of epidemiological perspective, you can see WHO in the 1990s, they established a goal to eliminate this tremendous public health problem by the year of 2000. Elimination, by their definition, was less than 1 case in 10,000 in endemic countries. And you can see between 1985 and 2000 that there was tremendous success in reaching that goal. The prevalence rate fell from 21 per 10,000 to less than 1, 0.37, so tremendous progress. Again, between those same years, the number of registered cases fell from 5.5 million down to about 245,000 persons. So the numbers are significantly diminished. I think one caveat is I think this disease still is probably largely very underreported, as I'm sure Dr. Saunderson will allude to. There's and many people think that this is a disease of the past, but it still is a problem that we've made great improvement on, but still a lot of work needs to be done. You can see here some of the countries that are still that still have a lot of problems in eradication, include India, Brazil, Indonesia, Bangladesh, and Nigeria. Dr. Paul Saunderson and American Leprosy Mission is an NGO that has made tremendous contributions to eradication of this disease, and so I'm honored to have Dr. Saunderson come. He's coming to us all the way from Norway today to speak about diminishment of transmission and total elimination of this disease. So Dr. Saunderson, I'll turn it over to you at this moment.
Thanks very much indeed, Lance. Well, just a few comments about transmission. One of the points about the multi-drug therapy that Lance mentioned was that it really began in the 1980s, and people were very hopeful that it would lead to a very quick clearing of bacilli and then a reduction in transmission of the disease. But what we found over the years is that it was more successful than we hoped in terms of treating individual patients, but it was much less successful than we hoped in terms of stopping transmission. And although the numbers, as Lance showed in that last slide, decreased very rapidly, these were the number of people who were being treated, but the new treatment actually shortened treatment tremendously. And so although there were fewer people on treatment, the numbers who were actually developing leprosy each year stayed very much the same, and it has really been very static over the few decades since multi-drug therapy was introduced. So in the last few years there's been a lot of thinking about how we can actually tackle the problem of transmission. And as Lance mentioned earlier in his talk, the mode of transmission is not completely understood, but we do know that the people who are most at risk of getting leprosy are those who are in the household or the near neighbors of new cases. So one of the ways that is being developed to try to tackle transmission is to reach out to these contacts of new cases. And so there's actually been quite a lot of research to show that if they're given chemoprophylaxis, actually just a single dose of rifampin, there's a great reduction, almost 60% reduction in the number of new cases in those household contacts. So that's being developed and rolled out. We're testing it in 6 countries in conjunction with the drug company Novartis. And there's a lot of hope that that will actually start to bring down the numbers of new cases and transmission on. And then we also, in conjunction with chemoprophylaxis using a drug, we think that there is also the possibility to use a vaccine to possibly in conjunction with the drug. They may work in a complementary way. And so at the moment, the use of BCG in contacts of cases is being tested in a trial in Bangladesh. But American leprosy missions, actually a long time ago, around soon after 2000, 2001, actually started to fund the development of a new non-live vaccine, a protein vaccine that would build on the immunity that children have from BCG given in infancy. And that vaccine is actually now just about to start phase 1 trials in America. So we hope in the next few years that we'll be able to test that in the same sort of context, in contacts of new cases, and see if that will greatly reduce the numbers of new cases in contacts. So that's where we're really going in terms of reducing transmission and, if possible, eradicate the disease, although there's a lot of controversy about the term eradication, and many people would say that as it exists in animals, in armadillos, as a zoonosis, then by definition it can't be eradicated. But we hope it will greatly reduce the amount of leprosy in humans, at least. I don't know if you want to move on to other questions or other discussions, Lance. That was what I wanted to say about transmission and possible eradication. But when people talk about eradication, I always think that with smallpox, it was actually eradicated in North America about a century before it was eradicated in the world. So if we can remove it from many countries, we'll be doing very well. And even if there are a few remaining pockets, to remove it from the most endemic countries would be a tremendous advance.
Absolutely. Thank you so much, Dr. Saunderson. That's very informative, and again, we appreciate your efforts and American Leprosy Mission efforts in contributing to elimination. And I appreciate what you're saying about eradication, but I think we are making great strides, and hopefully we continue to make that progress. I think at this time we can certainly open up the floor to questions. If persons have questions that they would like to pose to Dr. Saunderson or myself, yeah, just feel free, if you will, just to utilize your chat box there, just to pose those questions. Dr. Saunderson, while we're waiting for a question from our audience, where are some of the countries that you all are performing a lot of your work, focusing your work?
Well, there's a big focus of a lot of leprosy in the Indian subcontinent. So both India, Nepal, Bangladesh, and Myanmar are probably one of the major areas where we work. Our colleagues, Brazil is more independent and more capable of managing its program on its own, so there's less foreign involvement there.
Right.
And Indonesia is probably the third country in terms of the numbers of cases after India and Brazil.
Would
And
you say
then
that the I know, and I don't know the exact year that WHO made those drugs available and free of charge. Would you say that these developing countries, like you mentioned, India and Indonesia, even though they're available to these patients, do they have access to them in a timely fashion, or is that something that you're still really focusing and working on?
I think actually the drug supply for leprosy is very impressive, and uh, it was from 81, 82 that the regimen was developed, and then it's been free for about 2 decades
Mhm.
now. But Novartis, which currently provides the global supply free of charge, also assisted WHO with the drug supply. So it's a very impressive system,
Mhm.
and I've been to many places where there are no drugs in a clinic, but there are leprosy drugs. So I think it's as available uh, as any drug. One of the problems with people developing leprosy is that because of all the disability and deformity that occurs, there's a large amount of stigma and social
Mhm.
discrimination against people with leprosy. And so, sadly, a lot of people who may see early signs of leprosy on themselves, they try to hide it and hope it will go away.
Right.
So, it is mainly uh, individual patient's own perception and own willingness to come forward that is the problem, rather than the availability of the drugs,
I see.
I would say.
Yeah. Yeah, I think we have to. I concur with you wholeheartedly. In my experience abroad with patients with leprosy, you're exactly right. They're still very ostracized and stigmatized, and just because of the poor understanding of, how contagious they are, and persons are just afraid to associate with them. So we do have to work hard to, such that the public has a better understanding of the disease, and that they're not so stigmatized, and that they will come forward for therapy sooner than later.
We have another question from our audience, Dr. Plyler and Dr. Saunderson, that maybe you could address. This is from Skip Roy. He says, I assume the peripheral nerve damage is irreversible even with MDT treatment. Is that correct? Can you just address that, one of you?
Shall I take that?
Sure.
In general, we tend to use a period of 6 months as the cut-off point, that if the nerve damage has been present for less than 6 months, then there's actually quite a good chance of reversing it with a course of steroids, of prednisolone, as was mentioned earlier. But once it's been present for 6 months, then the chance of reversing the damage is very much less. And then, of course, there are all the sorts of secondary prevention of dealing with the peripheral nerve damage to try to prevent further worsening and further secondary damage. But if it can be treated within 6 months, then the outlook is very good.
Okay. Dr. Saunderson, could you also address, we have another question from the audience. Esther Guam is asking, is BCG protective in countries where it is given in childhood, or does it need a combination of chemoprophylaxis with rifampin and BCG to be administered at the moment of contact identification?
Yeah, the story with BCG is quite complex, because there are quite a lot of studies from different places in the world, and these different studies often give slightly different answers. So it does seem as if there is some protection from BCG given in infancy, and that may have slightly reduced the amount of leprosy in the world. And there's also, again, slightly equivocal evidence to show that BCG can help when it's given later. So there are some studies that show a second dose of BCG has no effect, and some studies suggest that it does have some effect. So it's very difficult to get the right answer, and probably the effect is not very large, but that's why we feel that if it's a vaccine in combination with the chemoprophylaxis may actually produce quite a good effect. So that's a lot of medical research is like that you have to, it takes time and money to do quite a large trial, and then the results are sometimes difficult to interpret or difficult to move forward from.
Great. Thank you so much, Dr. Saunderson. Dr. Plyler, maybe you can take this question from Wesley Harris. What is the approximate number of cases in Southeast United States per year caused by transmission through contact with armadillos?
Okay, wow, that's a tough one. So let me start off with, again, there are probably about 200 new cases of leprosy in the United States on an annual basis. And I think the vast majority of those are that occur from persons that come from endemic countries or persons that have traveled outside the United States that have been exposed. I think it's important to remember that the incubation period for leprosy can be years. It can be up to greater than 5 years. So it takes a long time before between the multiple exposures and clinical development of the disease. Armadillos are a reservoir for leprosy in the southeastern United States. There definitely have been cases reported where persons have actually handled armadillos for whatever reason and later did develop the disease. I don't think that anyone really knows specifically how many cases are transmitted annually directly from armadillos. Dr. Saunderson, you might be able to speak a little more specifically to that question than I can.
Well, I have a figure of around 30 per year of patients in the southern United States who develop leprosy who've not had a history of travel abroad. So that it probably varies a bit from year to year.
Right, and I think from what I've understood, the exact mode of transmission is poorly understood, but they certainly are a reservoir for the disease.
Yeah, that's correct, because people, obviously patients are asked if they've handled or eaten armadillo, and some have and some haven't, so it's a little bit difficult to know how the transmission actually occurs.
Exactly.
Sure, and from Wesley again, do medical staff that work with patients take chemoprophylaxis? What is the thought on that?
No, in general, not. Chemoprophylaxis is quite a new development, and as was said, the leprosy is not very contagious, and most people have a natural immunity and will never get leprosy however much they're exposed. So in my career, I've known a handful of health workers who have had leprosy, but the majority don't, and I've worked with leprosy for 35 years, and I never took any chemoprophylaxis.
Yeah.
Great. Well, thank you so much. If there's no other questions, I think we will begin to wrap up today's seminar. Special thank you to Dr. Plyler and especially to Dr. Saunderson for just your thoughts and comments and your presentation today. It was great. I want to remind our listening audience that CME is available for this session, and the form and instructions are in your email, and we'll send up a following email with the link to this recording for you to re-listen to again or to share with others. If you're not on our email list, you can join the forum at health.samaritans.org, and you can also be the first to know about our upcoming events. Our next webinar will be held on September 14th. It's a Wednesday, and it will be with Dr. Ben Roberts. We'll be talking about essential topics in ophthalmology, eye care in the developing world. We hope to see you then.